Wonderful. Thank you very much, Dr. Politi. I was thinking, we talk about difficult communication, and we didn't really get into how difficult it is to talk about what our care costs. So thank you for bringing that up. I'd like to invite our panel to come and sit, and we're going to have a few questions and then open it up to the audience. Thank you for all still being here. There is a reception coming next, but we have some good questions, I think, to ask, and I've got a feeling there's still some energy in the room here since we've covered some newer topic areas. But before we do that, I'm going to ask each of our panelists for their quick elevator speech. They're 2 minutes on what they forgot to tell you, but they really want to make sure you're going to go home with. So why don't you start, April?
Okay. Hi, everyone. We really know how to clear a room, don't we? Or maybe everyone decided to go online. Anyway, thanks so much for the opportunity. I think I made several points over and over again, so I'll just underscore two. One is that the public can't wait. They need to benefit from our research. So while you may not think of yourself as a dissemination or implementation scientist or a researcher, you have a voice in that process. We have to think about disseminating the interventions and tools that we talked about today. We have to think about how to better design our interventions to be ready for implementation. Second, health literacy and behavior is not static. It's not isolated. We don't live in a laboratory, as many of us know. And we don't just operate in health and public health just in the healthcare setting. And also, information is not enough. So we really need to think about what's beyond just health information and health literacy. How can health information, health literacy partner with other contextual interventions to ultimately impact health?
I guess one thing that I didn't have time to talk about was the tension between accuracy and clarity of information, but I did hear it kind of come up in other talks, and I think it's a really important point, and it's something that whenever I interact with genetic counselors and try to encourage them to simplify, it's a big struggle. I think it's a big struggle also in the area of consent for clinical trials. I think it could apply to a lot of realms. And what I always fall back on with genetic counselors is to say, well, would you prefer to be completely accurate or for your patients to get the main point and know what to do when they leave? And usually that's enough, or at least they're very polite. But I think it's something that we need to think more about and pay more attention to, because things just do get more and more complex. And certainly the last two talks address these issues too. It's how do you talk about health insurance in a way that simplifies but doesn't leave out the key information. And I think what that key information is depends on the context, so there's not a simple answer. So
I'll build on that idea. In most of the studies I presented, we usually measure health literacy and numeracy to understand our population, even when we're using convenient samples. And we look at this always as moderators of our effects, right? We expect when we have good visuals that people with limited health literacy will be, the usefulness will be amplified, and that, the harder to process information, the difference will be greater for those with limited health literacy. And what we find is that's not true. People with higher health literacy also appreciate good design and easy to access information. So if we design for people with limited health literacy, we can all potentially benefit because we can we can read it or we could process it or have the ability doesn't mean I actually have the time. There's a lot of demands in our lives. So just to reiterate the point that keeping limited health literacy as a population in mind can really help broader populations.
I think if I had to pick something that would be a good take-home message is that we don't have to know the exact costs that each patient will have from their insurance in order to talk about costs of care. We can know the relative costs of treatment and still talk about one being more expensive than another. One is a generic, one is a tier 4, one is one is a colonoscopy and one is a fit test, for example. And those kinds of things we can talk in terms of pros and cons relevant to a patient's situation. And I really think we should be including cost information more in decision tools about all sorts of things, not just about health insurance, because it is important to patients and they are making decisions based on cost.
Great points. I'm hearing the numeracy as a sort of a context we really haven't gone into much here, and how that's related to literacy, and I think that's very interesting, and the increasing complexity that is actually going to make it more complex for us in order to parse out our communication so that our messages get across. What any of you can answer this. What do you think are the real research priorities right now in addressing health communication as it relates to literacy?
So coming from a school of media and journalism, and my advertising is in PhD, so I'm not afraid to cross over to the dark side, if you will. What I see as a real barrier to us in health communication, thinking about tailoring. We talk about tailoring, we talk about targeting, but I don't see a whole lot of it in practice. We might show it just in small amounts for efficacy trials, and then we publish that, and then we kind of lose it. It doesn't take very much looking around at the media industry to see how they're tailoring and targeting and how it's effective. Now, whether we think that's ethical or not, that's another discussion. But we do know that our audiences enjoy it. We like it when we pick up our phone and Google Maps knows right where we are. We like it when we log on to Netflix and the recommendation is actually something we want. So in that same way, how can we better use data available in an ethical way to give the right people the right information at the right time? I would like to see that leveraged a lot more in health communication. I think we put up our own barriers and our own silos that actually limit us to reach people who maybe need the information the most.
How about the new oncology treatments? I think we're all very well aware that we have a lot of more complicated treatments. We're combining targeted therapies and immunotherapies with radiation and traditional cytotoxic chemotherapies. What do you think is the biggest challenge right now in communication research to make sure that we're able to communicate this new treatment options to our patients?
I think in a lot of cases, those distinctions are much more important to us than they are to patients. I think really trying to understand from the patient's perspective what matters. I think this comes up in genetics and genetic counseling a lot. I think I briefly mentioned that genetic counselors tend to be super excited about all of the developments in genetics and all of the new tests that are available to them. And when they try to share that with patients, a lot of times it's just not relevant. And I think what matters to patients is this test or is this treatment going to work, not whether it's an immunotherapy or a chemotherapy. So I just think really trying to keep in mind what is most important to the patient and focusing on our communication efforts on the patient perspective and the patient how the patient receives the information.
Nice answer. I think to bring us back to a patient-centered approach. You know, there's a lot of work to be done here, and I think we've heard different perspectives from the medical and healthcare communities as well as from public health and even journalism. How can we all better work And I'm gonna look at you right now, Allison. How can we better work together in our research to make sure that we're not working in our silos to address these issues?
Yeah, great question. Yeah, I think there's two pieces. One is community engagement and participatory work. I think a lot of us in the room have done that, and I think from the panel previously, it's really important to include that patient and community voice. And I'd also say not just the patients, but also the organizations that serve them. Sometimes our research questions don't necessarily match with people who are the boots on the ground that are actually doing the work. So if there's ways that we can partner with those organizations that really have the reach and sort of that engagement and trust in those communities, that's really essential. So that's one. I don't want to forget that practitioner audience. And then the second piece is really sort of transdisciplinary or multidisciplinary work. I think you can see even from this panel when the question was asked about different treatment options. Not only is there the genetic counselor and sort of the excitement about sharing all of this information and decision making for the patient, but there's also the financial toxicities piece too. So as we take more multidisciplinary, transdisciplinary approaches where we're bringing in different disciplines to better understand and target and tailor our interventions, I think that's at least a start.
Brings up, I think, one of the acronyms we heard this morning that is still resonating with me, and that was WEIRD. And thinking about how most of the research has been done, in a very small subset of our population and doesn't really embrace the cultural diversity of the people in our country now. So, how are we going to address those issues when we come up with funding opportunities, when we talk about clinical trials, when we develop those research questions that are going to be fundable? How are we going to build trust in a research world where it's not all about white people?
It's your turn.
I think thanks. I think the same principles apply that April was mentioning earlier. Engagement, making sure that you don't just have the same people on your team that have been doing this for years, that you engage the communities you're serving. You have extensive pilot testing. I know some people, you showed examples in your presentation of iterations of your design. We have the same thing where we think something speaks to us and it doesn't speak to the community that we're developing the tools for. So making sure that our research is relevant to end users. It goes from design all the way through implementation and everything in between.
I'll add to that. We also think, I'm working on other projects that I didn't share with you today, thinking about how do we design our recruitment messages. So I think a lot of times we're getting the audiences that are easiest to reach. They're the ones that are already plugged in, already looking for these messages or these announcements, and we're not using methods that maybe are a little bit more controversial or just unfamiliar to us. But we need to think about how we can reach populations that aren't just going to respond to the clinician advertisement or those posters that are posted in the various locations that those white populations or weird populations might already be in. And so that's something our team's really working on in using data-driven decisions to try to find people kind of where they are and trying to recruit from unusual places.
I'll just add to both of those really excellent comments. I was recently at a meeting and someone said, well, when you're encouraging researchers to work with communities, please ask the researchers to not be so condescending. So I think there's some self-awareness that needs to happen too, right? When you're working with communities and when you're thinking about health equity. Just because we're the scientists, and I don't think anyone in this room has this issue, but it is possible that just because we're the scientists and you come into a room, you don't know everything. There's local knowledge and history that has just as much street cred as a PhD or as an MD. So I think it's really important to recognize that. The politics and the history of a community, the power that they might have, the disempowerment that they might have when they interact with the healthcare system, the housing system, the food environment, the physical environment, all of that. But also, I think that we have to recognize the assets that are available in every community, whether it's white, Black, Hispanic, Asian, Native American. There's a lot of great assets that can also be leveraged, and coming together as a team in an equitable way can really advance that agenda.
Thank you. For you patient people waiting at the microphones, please introduce yourself, and we'll take your questions.
Sure. Stan Gerson from Case Western Reserve Cancer Center in Cleveland. This has been a terrific set of presentations and discussions. I've learned a lot. I have a question for Galen. You talked about the issue of managing and discussing hereditary cancer risk in low, underserved or broadly defined, less engaged populations. I didn't hear you talk about their families. And if you're talking about hereditary risk, how do you then branch out the dialogue into the family structure?
Well, a lot of those patients bring family members with them. So that's one way that's easiest to do it. One of the things that the counselors do, and I'm not a counselor myself, I should say, that the counselors do is to offer free testing to family members as they would to their patients. This can get quite complicated in immigrant populations, for example. There was one patient who actually brought a kit back with her to El Salvador to offer testing to her daughter. Or her sister, I think it was. But in any case, the family is not always available. I think there are also a lot of oftentimes cultural issues of communication with family members. It may not be something that all of these patients feel comfortable talking with family members about, either for cultural reasons or because the family dynamic is broken. So anyway, there are a lot of complicated issues. Cascade testing of family members is clearly one of the next frontiers, and it's a real challenge. I think it's a challenge in all populations. Actually, I'm not sure that it's more of a challenge in these populations, except in terms of availability.
Thank you for your presentation. Ivis Sampaio from SHARE in New York City. Dr. Galen, I had a question for you. With the women that you saw there, did you provide resources for them if they tested positive? And if so, what did you provide them with?
Yeah, that's a really important issue as
and
well.
I have another question after that, but
more broadly, when in the expansion of genetics to a more diverse population, one of the key ethical issues is making sure that if they do have a risk that's identified, that there are resources to address that risk, whether it's MRIs for a breast cancer risk or surgery or whatever the patient wants to do or the individual wants to do. And so, yes, in our setting, we were able to do that.
good. And then also, did you bring back the results of your study to the community? Because that's always been my pet peeve. Many researchers are doing great work. They're asking the underserved communities to become involved. But you're taking data, you're taking information, they're giving you this, and then it doesn't get brought back to them.
Right.
And I think that's very important for researchers to understand.
Yeah, and I completely agree with you, and I have done community-based participatory research projects in which we did do that, and that was a real commitment, was to bring the results back. In the context of this study, which was a clinic-based study, we didn't do that exactly. We did present to some patient support groups, in collaboration with the genetic counselors who were trying to explain what their service was and make it comfortable. But we didn't specifically report the research back to the individual patients because there wasn't an organization. Although over the years, I have presented at various community organizations like the local Komen Foundation and things like that. So I do try to do that, but I didn't have a clearly defined community to do that with in this case. But it's something we're thinking about more,
Absolutely.
even in that situation.
I would suggest that you be a luncheon or something, thank them for their participation, and just give them the information, because then they're going to bring that back to the communities at large, and they're going to tell the community, you should become involved because they bring you back information.
We sometimes also just do a one-page summary to individual participants, not even to like the community group, where we just send a summary of the whole study to the every participant who was enrolled in the study. If we have their contact information, that's still the same.
Okay, next question.
Hi, I'm Christine Gunn from Boston University and Boston Medical Center. So I guess you all presented very kind of interesting and different ideas around intervention in some way. And I think especially when we think about interventions that are targeted not towards providers, but to individual patients, we always, maybe it's because of our funding mechanisms, they're very like in a content way, very narrowly focused. And I guess, how do you all think about kind of raising that the way we do interventions around health literacy more broadly, and not being so topically focused, and how might we think about doing that moving forward?
Who wants to take that one?
Did my question make sense?
I think part of the topic-specific focus you see is often based on how projects are funded and then supported, usually by specific content area, but the principles behind all of the projects are the same. So I have an ongoing lab document that I keep for at least our lab, with lessons learned from projects that we then apply to our new project that's funded in a different topic, so the knowledge doesn't just sit within each individual piece of the puzzle. For example, like taking feedback back to participants, or the fact that our icons presented this one message that we didn't anticipate. So making sure all of our studies that are about decision support tools use these different icons that people then find more relevant and engaging. So that's just in our individual lab. In terms of the field as a whole, I often look towards these publications like the one that was mentioned by Rima Rudd earlier today, and some others that synthesized the decades of research on these topics and the key lessons to take away, so that we're building on some of the history of what people have done across all the different specific areas.
I just want to add to that, as I was thinking about, okay, so if we had one intervention that we know works within one particular cancer outcome, and how can we take that to scale to another? And I think two things. One is, what were the core pieces that worked in the intervention? And I don't think that we do that enough in intervention studies. What are the key ingredients, that special sauce that we knew was the key part of enhancing health literacy? And then there was this behavior change. Let's take this now to another study. We don't have that. We don't have enough of that. So I think as a community, we could probably, as interventionists, we could think about how can we share and understand what those core key ingredients are? How can we share the information about in which contexts and in which populations those worked? And can we track adaptations and adoptions that happen naturally in any community setting, and then share that with each other? We don't have to be embarrassed. If something works in one community and it doesn't in another, that's fine. But why? And then we can start getting towards that place.
Thank you.
Go ahead. Next question.
Afternoon, Lisa Fitzpatrick. Before my question, I just wanted to make a comment, and that is, I think it should be unacceptable for researchers to do research and not feed the information back to the community. Figure out how to do it, and if you need help, we are happy to help you do it, and there are a lot of organizations that can. If you're struggling to increase diversity on your teams, there are a lot of great organizations like Onboard Health who can help you with that. But my question is about trust. Your question about what the research agenda could look like. What are your thoughts about focusing less on the quantitative research and thinking about implementation science around trust and how we better measure health literacy, because tools like the Realm really just aren't getting the job done.
That is an excellent question. So I recently read this paper around organizational social capital. And in some ways, you could measure organizational social capital as trust, right? That's one element of that social capital. Sorry, as I was talking, I suddenly lost your question. You're asking about how we can incorporate organizations? And, oh, measure trust. Okay, sorry. Sorry. Thank you. Thank you for that. So one piece is around organizational capital and thinking about trust as one measure of organizational capital. If an organization has high capital to be able to do their work, part of that is the trust that they have. So that's one piece. I will also add that this is a growing area of research. We need better measurement and implementation science. There are so many different ways to measure the different implementation science outcomes. There are many different ways to measure health literacy. I think, and I might get in trouble for this, but I might not. Maybe this is a great idea. So this is April speaking. I think that you work with the community and identify what are among the measures that we have, what is the priority for you? If we need to measure trust, because that trust, and if we need to measure cost, if we need to measure social capital, if we need to measure fidelity, if that's important to you, then that is the measure that we need to select. And then similarly, what is the right health literacy measure that's important for the community? Because ultimately, if you're measuring and assessing the outcomes that are important to the organization and the community, I think that you'll get behavior change. And you'll get some important impact outcomes.
Go ahead.
Hi, Claire Saxton with Cancer Support Community. And I want to recognize all of the great research that you and your colleagues are doing to help us better communicate. But I also want to recognize that medicine and oncology medicine in particular is becoming much more complex at a very rapid rate. And, you know, one of the things that we see is that as new innovations happen, people talk about those new innovations in very different ways. And so you might have, in terms of biomarker testing for seeing if a targeted therapy is right for you, you might have the doctors talking about it in lung cancer as needing genetic testing because they know that the genetic testing of the tumor is better than the proteomic testing of the tumor. But when a patient hears genetic testing, they think of inheritable cancer testing. You might have industry calling it genomic testing or molecular testing because to them, you know, that works better with their marketing. And you might have patient advocacy groups talking about it as biomarker testing. And so patients are hearing about this one thing that's confusing enough, talking about testing the DNA of your tumor in very different ways from very different stakeholders. And so even having a common language talking about new advances is actually really important for patients understanding what's happening. But we also know that there was a survey done last year through the Harvard Precision Medicine Accelerator that looked at very engaged patients, because these were patients that were recruited from patient advocacy organizations. So patients that were really trying to get involved and give back. But 54% of them said that they were unfamiliar with the term precision medicine, and 84% that said that they were unfamiliar what immunotherapy was. And so how in this very complex and then add in the complexity of cost, especially as you're having these new innovations happen and maybe the standard of care hasn't yet changed, but there's ways to know if there are medicines that are even more right for you. And so how in this landscape do we really, how do we get these best practices out there in a way that industry, the healthcare providers, patient advocacy groups are all giving a consistent message and making these amazingly complex things like CAR T-cell therapy available to patients so that they understand what's the next step and what should they be talking to their healthcare team about. Are there some great repositories of best practices for health literacy? Because I think that would be a great thing to, add into this record for patient advocacy groups, industry, and groups that provide education to healthcare providers.
Maybe I could help you here with just, I think you brought up many very good points there. I want to address the one about a common language, because it's very hard to communicate if we don't have a common language. And it's certainly even harder to communicate that to people who don't have some of these other baseline sort of, medicalese, healthcareese. Is there a role for different groups, including clinicians, industry, and even health policy and journalism? Is there a space for creating a shared language?
I think that that's a great idea. I'm not sure how it would work in practice for all the agencies that you're bringing up, but I was thinking about what Dr. Fitzpatrick said earlier about trust, and also in her talk about starting with the basics. And we were talking about this at a break, that people really may not need to know the details of all of those new innovations you described to understand the need to know and need to do, which is the common health literacy breakdown of what do you need to explain to people? What do they need to know, and what do they need to do about it? And how do they need that information to make a decision? So can we break it down into, what would you try to explain to your mother, sister, brother, cousin, whomever, about the information enough that you can support them in making a decision, and no question should be too basic. And I think if we start out talking about immunotherapy and new innovations, we're going to lose people right away because the topic is so complex. So I think if we can start with the basic information, and it may not be a common language across all those institutions that they adopt, but a common process of just meeting people where they are and knowing that there's a lot that's confusing, but maybe we can start with something simple to help them get there.
That's a great place probably to end. Did you have a question too?
I just wanted to point out two resources just in response. So there is something called the AHRQ Health Literacy Toolkit. So that's a repository of dozens of responses to what you're saying. But also, if you could put, this topic came up a few times in terms of measurement tools for health literacy. So this is another resource for people to use. There are currently 191 tools on the website. If you click on cancer, it scrolls down. You can filter down. There are 13 tools on cancer. So there are some resources out there. This is not to say that there's not important ways for this to improve, but this is a curated site that can help you find a lot of the measures that are there. So those are two types of resources that kind of respond to a few of the topics that came up. Certainly, Realm is not the only answer.
Thank you. That's great to see the resource up there. Do we have time for one more question? Yep. Okay, go ahead.
Hi, Deborah Collier, Patient Advocates in Research. So thank you. This has been a very interesting day. I think, we've heard a lot of common themes, but a lot of good suggestions as well. So I wanted to kind of add to a little bit of that and maybe ask for any comments. There are a few things that we haven't heard that I think may also be useful to bring into the dialogue. We haven't heard anything about patient experience data, not just PROs. We haven't heard anything about patient preference data, and both of those are evolving fields that are a natural, I think, as we start to bring in health literacy into the way we do things. A lot of what we haven't heard, you guys talked a little bit more about it, and some of the last panel did as well, but we seem to have had a lot of discussion about how we give information now and what we can do with health literacy instead of how should we give information in better ways, right? And not just give information, but have that multi log approach. So it's not a monologue anymore. It may not even be a dialogue. It may be, involving the family as well as the patient, as well as the healthcare provider in a way that creates a better environment. So I was just wondering, based on some of those ideas, what would you guys see as maybe the top one or two topics that might be good to build a common language and an approach where we're integrating some of these pieces together?
Well, I'm not sure if this addresses the latter question that you ended with, but what you were asking, or what I understood you to be asking early in your statement, was about patient experience research, and all of the interventions that I talked about were based on really in-depth patient experience, observing them in genetic counseling, and then interviewing them after their genetic counseling, and just having a dialogue with them about their experience of that counseling appointment. So the qualitative research is really essential to understanding patient perspectives and patient experiences. And I do think that in addition to the kinds of measures, quantitative measures that are out there, I really strongly advocate for that kind of qualitative engagement, not only in interviews, but in observations and other less clinic-based interactions in communities, because health and healthcare doesn't just take place in clinics. Thanks.
That's a great summary to take us back to. It's really about the patients and what they're seeing and what they need to know and what do they need to do. I think those are all really good points, and it takes it back to that simple language again. So I'd like to take an opportunity to say thank you to our panel